OB operations is about the more common OB operative procedures. What you have to know from this lecture is the indications of each procedure and then some of the risks or benefits you get by performing that procedure. You will not have to know how to perform the procedure itself, just when to choose that procedure for each given patient. We're going to compare indications and risk benefits for each of the more common procedures. Let's start off with the C-section. We're going to compare each procedure, their indications, and the risk or bonus you get by performing them. And the quintessential procedure that you will do as an OB is the C-section. The C-section is usually performed by making an abdominal incision, either a midline incision from the sternum to the pelvis, which is done in a crass section, or it's done with a bikini cut, which is at the waistline. That gives you access to the uterus. An incision is usually made in the posterior of the uterus, which allows access to the fetus, taking the fetus out, clamping the cord, cutting the cord, and then working on the placenta. The indications for C-sections is very large. First off, mom may just want it done. She doesn't want to have a vaginal delivery, and this is in a controlled setting, so she gets a bikini cut. Other indications for C-section are either fetal distress or maternal disease. What I mean by that is if baby's in trouble, a non-reassuring CST, that is, she's in normal vaginal delivery and all of a sudden something goes bad with baby. If there's a breech birth that prevents baby from being delivered in the normal fashion, or there's maternal factors such as preeclampsia or eclampsia, you don't have time for a vaginal delivery. You've got to get baby out now. Now there's many more indications than this, but the idea is that if baby has to come out now or very soon, C-section is preferred. And generally you want to get it done before you need to go for a crash section. Crash section leaves mom with a huge scar, where if you do a semi-elective procedure, that is an urgent C-section, you may still have the bikini cut, which preserves mom's aesthetics. But in performing a C-section, you gain access to the peritoneum, which means that if a mom wants a tubal ligation, you can do the tubal ligation, the bilateral tubal ligation, the BTL, at the same time you take baby out. The risk, of course, is that you are cutting into the uterus, so that if she attempts to have a vaginal birth the next time, you'll have vaginal birth after cesarean. That scar on the uterus is not as strong as the myometrium was, and so vaginal birth after cesarean carries the risk of having a uterine rupture, which is why you generally do not want to have a vaginal birth after C-section. And because constantly cutting on the uterus causes major problems with the uterus, most OBs only want a woman to have 3 or 4 C-sections. Thus, a very common problem is after 3 or 4 C-sections, that 5th birth, do you let her go vaginally or do you bring her back to the operating room? That's not a decision you'll have to make. And because mom is your patient, the risk, of course, is leaving a scar. The bikini cut is done to stay below her bikini line so she can go back out to the beach. But if she has a midline incision, she's going to have to deal with that scar for the rest of her life. So this really isn't a reason to do it or not do it, but just be aware that in the decision making, mom may not want to go through with a vaginal delivery, but at the same time cares more about what she looks like when she's done. So maybe the C-section is not the best idea for her. The next sort of delivery is 2 modalities that do the same thing: forceps delivery and vacuum suction. C-section is done when baby's got to come out and it's not near the vaginal opening. Forceps delivery and vacuum are essentially an assist to get baby through the vaginal canal. So if baby's almost done being delivered and they're in trouble, you can kind of go in through the front door, grab baby, and pull it out. It's difficult to do with your hands, but the forceps and vacuum suction allow that to happen. So the indications for forceps and vacuum delivery are the same. It's fetal distress. Baby's not doing well during the normal vaginal birthing procedure, and they're at station either +1 or +2. And of course that means that there's cervical effacement already. This sort of goes without saying, but it is one of the required indications in order to use forceps and vacuum suction. Baby has to be almost out of mom in order to use these procedures. And the way you do this actually with forceps is really just a pair of tongs. You insert the tongs in, you grab onto baby's head, and you yank them out. With vacuum delivery, it's a little suction cone. You insert it in, put it on baby's scalp, turn on the vacuum, it sucks baby's head, and you pull it out. The risk with doing these procedures, though, is that you're manipulating soft tissue, both mom and baby, with some pretty hard force. So forceps delivery can clamp onto baby's head, first causing a cephalohematoma, but can also induce a Bell's palsy by squishing some facial nerves. Vacuum delivery can cause the same sort of hematoma, but if you don't get just baby, that is, if you put the vacuum cone in and mom's tissue, mom's vagina gets stuck in the vacuum, you can denude mom. So when you perform a vacuum procedure, make sure you put your finger in and kind of make sure it's only baby's head and none of mom is stuck in there. And so in order to understand when forceps and vacuums can be used, let's take a look at what station means. You've probably encountered this a couple of times in this lecture so far, but let's just make it clear in this lecture in case you haven't. Here's the uterus, and there's been cervical effacement. This is the vagina. This is sort of the midpoint called station 0, and the vaginal opening. A fetus, before its head engages, is at station -3. When the fetus's head engages the vagina, or the cervix rather, it's -2. As it begins to enter the vaginal canal, it's -1. After it passes this midpoint, which is sort of arbitrary, it's sort of called the pelvic floor, but how can you tell when a baby's in here? If it's more out than in, it's station +1, and if it's at the very end but just can't fit through, station +2. These are the indications for forceps and vacuum. The same indications that would have you use forceps and vacuum tell you to use C-section at a higher station. So far we've talked about C-section, forceps, and vacuum. These are sort of the delivery procedures we can do. But now let's start talking about some other procedures that an OB might have. So an episiotomy might be used to help get a macrosomic baby through a first-timer's birth canal. Basically what you do is you cause a vaginal laceration, but it's a controlled one. You basically take a pair of scissors and you cut the vagina. What you're doing is sort of opening up the hole and making it bigger for baby to fit through. Now, a joke OBs will use is that there's no indication for episiotomy except for resident learning. The idea is that if you just wait, eventually baby's going to come, and if baby gets in trouble, you can help pull it out. But the indications for episiotomy is a big baby fitting through a small tube when things are taking too long. That is a nulliparous mom, a macrosomic baby, or prolonged labor, especially in preparation to try to prevent shoulder dystocia. The risk, of course, is that you're causing a laceration, and that this can present with postpartum hemorrhage. If you make the cut, you're going to have to suture it back together. And there's two types of cuts you can make, a medial incision and a medial-lateral incision. And the risks are different for each one. A medial incision heals, hurts, and has the potential for grade 4. We'll talk about grades in just a second. Medial-lateral does not heal, does not hurt, and there's no risk for grade 4. Which you use is really up to the operator. The OB will decide at the time. And here's the idea. When you have a patient, you're going to make an incision into the vagina. What you're worried about is creating a laceration that goes into the anus. A medial incision is medial, and you have the potential to make that incision too deep, or for you to make that incision and then for it to continue to tear into the anus. A medial lateral incision is off to the side, so that if it tears, it continues to tear outward, but can't tear into the anus. And so medial, lateral, medial, doesn't really matter which one you choose, but you have to understand the consequences of doing one over the other, which means you have to understand the grades. Grade 1 is vagina only. This is ideal. This is what you're going for. You don't want to cut deeper than that. Grade 2 includes the vagina and the perineal body. You're sort of working your way in between the vagina and the anus. A third degree episiotomy tear or a vaginal laceration tear is going to include the anal mucosa, getting really close. And a grade 4 is when you're involving the anal sphincter. This is really bad and is the worst because not only do you have anal incontinence, but now you can actually form a rectovaginal fistula, which means that if you do go this route, you have to make sure you do a very good job suturing this laceration closed. Episiotomies are used to prevent uncontrolled lacerations or uncontrolled tears, but recognize that by cutting into the vagina, you can lead to more severe disease. Medial, hurt, heal, and have the potential for grade 4. Medial lateral, do not hurt as much, do not heal, and there's no potential for going into the anus. Choose which one you want, discuss with your patient. But in preparation for succeeding until delivery, where C-section, forceps, vacuum, and episiotomy can be used, sometimes mom needs a little help saving baby long enough. And that is when the cerclage comes into play. So if mom has an incompetent cervix, say she had a cone biopsy for a cervical lesion, and she's had multiple first trimester losses, that is, the cervix releases baby too soon, you can actually go in once baby is ready, that is, sometime in the first trimester, and apply a purse string suture. You would basically tighten up the cervical opening. And then, when mom is ready to deliver, simply go in and cut those sutures. The idea is that the cervix is incompetent because, for whatever reason, and you provide a suture that closes it shut. So the indications for cerclage are a known incompetent cervix, or multiple first trimester losses, which you presume are a product of the incompetent cervix. But think about what you're doing when you do this procedure. You're going to put a needle through the cervix multiple times, making a purse string. There's a baby in there, right? And despite what I've drawn for you a couple times in this lecture, the entire uterus is taken up by the amniotic sac and the placenta. So you could accidentally nick baby while you're putting those sutures in. If you do that, you'll induce a preterm, premature rupture of the membranes. Remember, you're doing this very early on, before the end of the first trimester, so if you have a rupture of membranes then, baby's likely to be not viable. So you can actually cause fetal loss if you do this procedure poorly. And likewise, if you don't cut those sutures before the cervix begins to dilate, the cervix is going to dilate anyway, and you may just rip apart her cervix. You might just cause cervical rupture. So make sure when you put the needles in, generally week 12 to 16, that you then take the sutures out around week 35. And then finally, during delivery, you're going to want to make sure you apply decent anesthesia. And there's a lot of options for anesthesia. The two you're going to see the most are going to be analgesia, that is narcotics, and the epidural. The epidural is a needle placed in the epidural space. If you feel the pop or you see CSF, you've gone too far. You do not want to put anesthesia directly into the spinal cord because it will cause respiratory depression and hypotension as you shut off the entire spinal cord and diaphragm. With the epidural, what it does is essentially eliminate sensation below the point of the epidural. This is great as contractions begin to become painful. The problem is that mom won't be able to feel the contractions and she won't be able to push. So using an epidural means that labor is probably going to take longer, that you're going to need to use more invasive procedures like a tachometer, and she's going to need a coach for someone to tell her when to push. Likewise, an epidural is a great way to do a C-section because mom can be awake when baby comes out so she can hold her baby for the first time. Analgesics are often used with just about everybody. Birth hurts. I wouldn't know anything about it, but I've certainly seen a number of women suffer through the birthing process. And narcotics are used to control their pain. The problem with narcotics is that one, if they're given too early in the latent phase, they'll cause prolonged latent phase. And two, if they're given too late, that is towards the very end of delivery, baby's going to have some narcotics in the system, and it might be a blue baby. That is, they might need naloxone to reverse the effects of narcotics to wake them up. So analgesics are good to control pain, but what they can do is produce a prolonged latent phase. This actually is the most common cause of prolonged latent phase. Physicians don't want their patients to hurt, but they haven't given enough time for the process to get started, and we kind of shortchange them. And it increases the need for newborn naloxone. Generally, the analgesic has to be given within 1 hour of delivery for this to happen. But just be aware that if you're giving a patient narcotics and baby comes out and is not doing so well, there's probably narcotics on board. And the epidural is a great way to control pain, but if you accidentally misplace it, mom can get hypotensive. That is, if it's in the subdural space. And even if it's not, mom won't know when to push. So prolonged labor is a common complication and should prompt the placement of a tachometer and a coach. There are other kinds of anesthesia, and generally they are local anesthetic to prevent individual stages of labor. You don't have to know what stage correlates to what segment of the spine or what nerve does it. Just recognize that there are two other local anesthetic procedures you can do. The first one is a paracervical block. A paracervical block blocks the pain of cervical dilation. It is used to prevent the pain of stage 1, that is, when the cervix is dilating. And what a consequence of putting lidocaine very close to the cervix could be that you get some into baby. And so if you use a paracervical block and you see fetal bradycardia, don't freak out. This is not an indication to go to crash section. You just got some lidocaine in there, and as the lidocaine wears off, so too will the fetal bradycardia. This is almost the only time, and probably the only time on your test, you'll see bradycardia that should not result in a C-section. So look for paracervical blockade with lidocaine if you see fetal bradycardia. If one of the answer choices on your test is reassurance, look for that procedure. And finally, there's pudendal nerve block. This will prevent the pain from stage 2. And really the only complication for this procedure is that you miss and she still suffers from pain. But I'll make the argument that if you are in America and you're going to use anesthesia, you might as well just put in the epidural, which is why the amount of paracervical and pudendal blocks have significantly decreased. Ready to back out? Back out. And so in this lecture, we've covered some of the more common OB operative procedures. Generally, they focus around getting baby out. One procedure, the cerclage, keeps baby in. Just make sure you understand the indications and the risks of each procedure and know what you should recommend for each patient. C-section, operation of choice to get baby out. especially if the station is above 0, that is in negative ranges, that is inside mom. If baby is almost out, choose the forceps and the vacuum delivery. Just watch out for Bell's palsy and don't catch any of mom's vagina in the vacuum. Episiotomies are generally avoided unless they're absolutely necessary. Medial hurts, heals, and can cause grade 4. Medial lateral does not hurt, does not heal, and cannot cause grade 4. Be careful putting the needle in for a cerclage and make sure you take them out. And finally, anesthesia is either narcotics or epidural, and some of the rarer ones that you're not really going to see that much. That is OB operations. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.